the diet parts. And my question would be to know, how have you gone about in challenging the negative messages with regards to diet and medicine? When it comes, especially within Black communities, how have you gone about challenging some of the messages that we see? Anybody? Yes, Ms. Stillman, you can go ahead.
Okay, thank you. So one of the ways that I've been taking this on in my own life and sharing it with others, there's an organization called girltrek.org. Mm-hmm. And they're all about having Black women walking and moving their bodies for a minimum of 30 minutes a day, and then kind of taking on listening about our ancestors. So it's an interesting motivation to get your body moving, because mostly we can find 30 minutes in a day to do something, right? And there's always recordings. And I know for myself, I started this practice in June, and there's this particular place where I hike, and I just came back from there, where I was like, I can barely get up this hill. Like, I was just complaining and whining. And then I was like, oh, wait a minute. So my ancestors walked really far and their lives were in danger. And so, like, I can get up this hill. So there's just that kind of simple thing around, I can move and I don't need to pay money to be in a gym. I don't need to have any particular skills. So I've just been encouraging people in my life to, like, you can at least put one foot in front of the other, and that you can just reap the benefits of fresh air and doing something for yourself. So that's one of the things that I've been encouraging people to do, as well as being mindful of, what are you putting in your body? Like, you get to choose. And so that's what I've been taking on.
Definitely. So Nila, you are a wellness coach. I know that a lot of your practice is around physical activity and diet, and you have a very specific approach to diets and physical activity. Can you talk a little bit about this with regards to some of the negative messages that we tend to hear about diets specifically?
Yeah, so I did my education in the States. So, we learned about like diet and how to teach people how to eat healthy. And I was like, okay, I got my education. I'm gonna go teach people how to be healthy. And what I found is that this information is really not, it wasn't in alignment with the people that I was speaking to. And, the prescribed way of eating healthy just was really not in alignment with my clients when I actually brought it to the table. So I literally had to almost go back and re-educate myself, which was when I realized that a lot of this information is very much written from like a Western perspective. And so it didn't align. So I had to literally teach my clients, okay, this is what you have available to you. How can we take what you have already and make it healthy? And so, speaking more specifically to like, to Namibia and African culture, it's taking like, what are the traditional foods that we have available to us, and changing the narrative that this isn't unhealthy food. We're very much taught that like Western and European is the way to go as far as like eating healthy. But, I came here and, no one knows like what people don't have pomegranate just, down the street. So literally getting back to the core of understanding what is actual healthy eating and how can we make it ours? How can we look at our, traditional cultural ways of being and living and eating, and how do we reframe that to make that good as well? What I've learned a lot from observing, my clients and everything is that diet, again, being written from like a Western perspective, like diet is a way to is a way to weight loss. Like that's all people, like if you say diet, people immediately think, okay, I go on a diet to lose weight. So I really had to get back to the core of re-educating just to the very, very basics of what is our healthy eating, how can we heal our relationship with food, how can we eat in a way that is supportive to our mental, physical, and emotional well-being. So just, again, getting back to the core.
Definitely.
Yeah. So I just wanted to follow up on Lau's comments because they resonate a lot with me in terms of my observations in the African immigrant community. So the issue of diet is complex, right? So your diet is shaped by your culture and your local context. So your comments about sort of the disconnect between the Western way of eating, and when you say diet, people think, well, you want me to lose weight. That's consistent with my experience in the US. And there have been a number of studies that have shown that the Southern diet is associated with the higher risk for heart disease, right? But one of the challenges in the US is that often people don't recognize that the Black population is very diverse, right? Even on this call today, we can already see how diverse this group is in terms of ethnic heritage. And so if you have an African immigrant patient and you're talking to them about the Southern diet and collard greens or chitlins, or you've lost the patient, right? So you need to know who you're talking to and their background. And then when we talk about the DASH diet, right, the dietary approaches to stop hypertension, right? When you have an African patient or a Jamaican patient, how do you counsel them to improve their diet when they are not African American? And the challenge is that a lot of healthcare providers often don't recognize the heterogeneity in the Black population, so it gets in the way of providing culturally appropriate counseling. And so I really do acknowledge that the sentiments you shared about your experience in Namibia is very similar to complaints I've heard from the African population in the US.
Definitely. The other thing I wanted to, I guess, just a shameless plug before I ask Ms. Mo Chunks to tell us about her interaction or her experiences with diet, is there is Black chefs on Twitter. So you have just like we have Black in cardio, we have Black chefs. And even when we talk about the Southern diet, there's a lot of stigmatization when it comes to Black food and what it means in terms of health. It's like the lack of knowledge when it comes to the healthcare professionals, when it comes to the research tends to be a little bit, you can feel it. There's just this very much of a negative approach to understanding Southern food. So, and the food that Black people in all their heterogeneity eat. So if you want to, definitely check out Black chefs and see the work that they are doing with regards to food in Black communities. And I will let Ms. Mo Chunks tell us more about her experiences when it comes to how do you counteract these negative messages around diet?
Hi, everybody. So my name's Mo. How's the camera looking? Everything okay?
Yes.
Great, thank you so much. So my name's Mo Chunks, as they said earlier. I had an interesting journey with my weight. After university, I got up to like a size 18, 20. And I started to research how, to lose weight, basically. I'd kind of gone up and down with my weight as I'd gotten older. But after university, I said, okay, I actually want to keep this off forever. So I said, okay, what is the science of weight loss? Having a science background, BSc medical physiology, learning about health and disease. So decided to research this and basically found that, as many of us have rightly said, there's nothing wrong with our African, Afro-Caribbean diets. It's just the way we cook it sometimes, it's our portioning. So I started to learn about, like the carbs that we have, and how we can really segment things into food groups properly. So in creating my book Losing Weight Nigerian, what I tried my best to do was really highlight to people that, look, Nigerian food, that's where I'm from, I'm Nigerian food is not terrible, it's just the way sometimes we cook it, it's the way we portion it sometimes. So I think that's pretty much the work I've done in terms of challenging our ideas of, African food is bad for you. African food is the reason why you are unhealthy, because I'm a testament that you can be on a quote unquote an African diet and still lose weight. And as someone rightly said, I heard someone saying that when you hear diet, you think weight loss, but also changing that narrative around it just being for weight loss to it being about healthy eating and creating a healthy lifestyle, even with the food that we've grown up, loving. And I think there was somebody that just said that, they've had challenges with when they have maybe like Afro-Caribbean clients, and, they can't necessarily put them on a diet that is not theirs. So in doing those things and understanding food groups, I think that's the best way, that I've learned to really challenge ideas surrounding our diet and, the medicinal properties of them as well.
Definitely. So keeping up with the diet, we are talking about how we do engage with the diet in our own life, how we interact with the diet in our own life. But the question is, how do you engage Black communities with regards to diet? How do we make it so that we speak in a language that is understandable, that is relatable to Black people, and that is not stigmatizing? I think one of the things or the issues that we really have to stress is the way that we talk about Blackness. Everything that is related to Blackness, including diet, tends to be very negative. So how do we engage with Black people, Black patients, if you're like Dr. Alexander, or Black clients with Ms. Chunks and allow Black participants in our studies? Because when you do studies, especially community-based studies, at times you have to start talking about these issues, because you see how people are living, and it's very hard not to give some type of advice. So how do you go about interacting with Black communities, and how do you go about putting that message out there that you have to eat healthy, but in a way that is relatable, not stigmatizing, and quite positive? Dr. Alexander, you were about to say something?
Oh, sure. Yeah. So, I'd say it starts with listening to the community. I mean, I think as medical professionals, and myself included, it's very easy to kind of be, to tell people what to do and give them advice and say, you should do this, this, and this. But I think, from what, all the terrific comments we've heard from panelists so far, every patient's different, has a different background, different belief system. And I think the first important step is to really listen and understand what that patient's individual living situation is and what their views are in life. And I think in terms of outreach to the community, that we expand that to say that as medical providers, we need to go to where patients live. So whether it's church groups or other community events, and listen and understand kind of the population that we're working with first. And I think that kind of sets the stage for having a dialogue where, instead of being the person that goes in and says, you're doing all these things wrong, or this is bad, you should do this, it's, this, okay, I understand, these are kind of what you're currently doing, what the challenges are. Here's some advice to how to, or here's some things that we could try to figure out how to work in that system. Example I'll give you, I mentioned I study cardiac amyloidosis, and it's a condition that's very underdiagnosed among African Americans. And so now that we have treatments, there's a lot of interest from different players, industry, the medical community, policy folks, about how to improve the diagnosis. And I think on the medical end, you could say, well, we just need to do more echocardiograms and EKGs and, get people referred to cardiologists. And, certainly that's a piece of it. But I think, one thing I've learned going to church group meetings or other kind of community-based conferences that include a large Black population is that I've learned a lot about what it'll take from the other end to improve diagnosis. So, if you say, well, yeah, I mean, I'd be happy to go to Stanford or wherever else, but it's, 300 miles away, and, the appointments take 3 months to get to get in, and there's these issues with insurance and so forth. So, that's kind of eye-opening for me. And, that kind of gives me a sense of what I need to do, instead of, it shouldn't all be kind of what the patient needs to do to get diagnosed, but how do we change the system from the medical side to facilitate patients getting diagnosed. Because I do think there are some structural disadvantages that can make it hard for minority populations to reach tertiary health systems or reach the right people in those systems. So that's something that has to be changed on our end. So
Definitely. And that is, thank you for introducing the other side of the argument, because we are talking from diet to medicine, so we see everything in between. So our next step is going to be physical activity, which I guess is also a big component to it. And we touched upon that. We touched upon that yesterday a little bit when we were talking about some of these issues around stigmatization, that there are, the research shows that Black people exercise at a lesser extent compared to white people. But there is this argument that people don't really think of, is just the racial components, or the society in which people live in, and how that might contribute to the lack of physical activity. So can you talk a little bit about just these negative issues surrounding physical activity, and how it is also steeped within these racial structures of the United States? I know that Ms. Stillman mentioned Girl Trek, and I definitely follow them and hear about their message, because really physical activity is, when it comes to Black people, there are a lot of issues that you have to think of when talking about it. So can you talk a little bit about these negative issues around physical activity and how it's linked to just the racist society in which we live in?
I can go.
Yes.
I think a lot of what you all have shared so far is what contributes to that, right? It's that negative perspective of Black African Americans. And I think a lot of the changing the narrative is to have images that actually reflect that actually Black people do hike, they go swimming, and also just kind of acknowledging that exercise doesn't have to be you signing up for a gym, as Janet mentioned. It could be something as simple as every day going around your block and just taking a walk around the block. One of the things that, depending on what areas that you live in, you might not have easily access to parks where you can walk around and, do more physical activity there, but kind of just changing what exercise actually looks like. It could just be something as simple as taking a couple walks around your block and getting in that physical activity. So I think just kind of reinforcing the positive images that we do these things naturally, and just bringing more awareness to the things that we're already doing in our lives.
Yeah. Yes, Ms. Tillman.
So 2 things. I see a question in the Q&A back to food. And I just wanted to mention, Josh Knowles said, what about the issues with food deserts, and that the inability or difficulty to get fruits and vegetables in the diet? So I wanted to make sure that we touch base upon that.
Yeah.
Part of what I was thinking around that is, gardening, it's not a lost art, right? And depending on where we live, we can put little pots even in our house. And so just to make sure that it doesn't seem exclusive, whether we're talking about food or exercise, because a lot of these things make it seem like there's a lot of money or a lot of time or something that's not accessible. And so that's, as Amelia also mentioned, it's like, you know, you can move your body. I mean, we like, you know, a lot of people like to dance. I mean, it's, some of it is finding something you like to do that actually is some movement and the consistency of it, right? So the same with the food, like what do you have access to? There's a lot of bartering that people do as well, especially in California. Like, oh, like a friend of mine had this persimmon tree. She goes, oh, I have a bunch. You want to come and get some? And someone else says, hey, I have this. Do you want to trade? And so it's nice to kind of make that a community conversation as opposed to having the struggle on your own and then feel defeated. Like, oh, okay, I did one walk. But if you're realizing, like, you kind of do a challenge with someone. I'm in this Nike run challenge with a friend of mine where this month we're walking 100 miles this month, right? So every time I do my walk, I take a snapshot, a screenshot, and I send it to him. And if he's not wanting to walk, I'd be like, okay, I better get out there, you know. So just making it kind of fun as opposed to like, oh, I got to get out there, because we all know sometimes it's hard to get motivated. But again, if it's the half hour, or it's like, hey, I ate really well today, or I lost some weight, or whatever that is, and to find some realistic goals around the eating and the movement, I think that makes a huge difference.
Definitely. And I think you are definitely right when it comes to understanding that gardening and exercising are activities that we can do if we put a little bit of effort into it. But can we talk a little bit about the policy side of things? Because when we talk about, for instance, yesterday we had a very interesting conversation around the stress level and how sometimes Black people do cope with the very stressful situations that they are in. So for a lot of people, the coping mechanism for everything that is happening around the country would be eating. So you cannot ask them to stop eating without necessarily addressing some of the issues that come with the stress. When you talk about physical activity, we are asking people to, like you said, Ms. Tillman, that walking around the block, but what if you live in a space where you don't feel safe walking around? Or what if we had issues like with the recent killings of joggers, or Black people just doing activities that they normally do? That's really just, does touch on the psyche of the Black population, because we start getting scared. So how do we address these issues? How do we ask people to still exercise and to still eat healthy while recognizing that they are living, the conditions in which they are living might be very difficult? How do we make a message for healthy eating and physical activity while recognizing all these other issues that come with living as a Black person in the United States, in the UK, even on the African continent?
Can I jump in there?
Yes.
I think it's a difficult one, but I definitely know that people like to be heard. So I definitely know that people like to be understood as well. So as you've rightly pointed out, I think it's important to acknowledge the situations that they do find themselves in, acknowledge the environments that they do find themselves in, and acknowledge that it is stressful, and possibly add into why they're not able to have a healthy diet, exercise, lifestyle. And then once that's kind of acknowledged, definitely from there, you can start finding solutions to even the root of the matter. So the things that are stressful to them, because I believe that, you know, physical health, it ties in with your mental health as well. And like during my workshops, when I do Losing Weight Nigerian and I do the healthy eating workshops, something I definitely do start off with is reminding them of like mindfulness, and the fact that sometimes the reason why we do like eat the way we eat is because we need to lose some other form of weight, and that's the weight of trauma in some cases. And, you know, that can be unpacked with, a therapist, a counselor. And I know that isn't always accessible, again, because of money. But there are definitely services that, if you research a tiny bit more and we're able to, like we said, community, help each other out, we can point people to services that can help us to, ease off some of those stresses, because it's like there needs to be an outlet for something, right? Whoever comes in has to come out. So encouraging people to use these, free services, also recommending people, like my therapist, because of my age at the time, I got it for free. So things like that, and letting people know that these things are available, and actually then going on to recommending other outlets for stress. So things like, we had the PE teacher that blew up this lockdown period, because he was able to create a service that you can do within the confines of your home. I think once you begin to go through those layers and really unpack those things with people, they will be more willing to listen to your okay. This is why I think you need to exercise, and these are the other options. Even though you might be in a community where you might not feel safe going outside, for example, you can turn your laptop on, you can listen to and watch replays if you don't want to do it with other people, because sometimes it can still be a bit like nerve-wracking. And then I believe that people will be more receptive to our suggestions, because I think everybody knows pretty much the benefits of healthy eating and exercise. It's just a matter of, have we decided to prioritize it enough, or do we find it important enough, or have we found the space in our lives for it before we can actually begin to go down that healthy lifestyle route.
Yeah. Definitely. Any other comments from our panelists? Yes, Dr. Mensah.
Yes, I was just going to highlight some of the issues that Mo raised. And I think community-based interventions provide a real opportunity for us to have an impact. It's one thing to tell a patient, you should eat 5 servings of fruits and vegetables, right? And to your point, Deborah, about policy, but if someone lives in a food desert and doesn't have access, so how do you elicit that type of information? You have to ask the right questions. So assessing social determinants of health in a clinical context or in a healthcare encounter, that's really important. You want to know, do you feel safe in your environment? When you tell a patient you should exercise more, you expect that they will adhere to that recommendation. But if their neighborhood is unsafe, they're not going to do that. So we have to ask the right questions. And going back to the comment Janet made, ask people what they like, right? So for some people, they love to dance, myself included. If I'm not motivated, all I need is some Afro beats, right? And my jump rope, and that gets me in the groove, right? So we really need to shy away from some of these traditional ways of counseling patients. Well, if you tell me to go to the gym, that's not going to happen, right? But if you offer an option that involves music, dancing, and we know that culturally people just love to dance, right? Yeah. So we need to ask the right questions and make sure that we provide opportunities in the community. So I'll give you a concrete example. So my son's 7 and he has a bike, and during the COVID sort of pandemic, there's a trend that started in our neighborhood, and this was not planned, where around 5 o'clock, the kids in the neighborhood come out with your bikes. So now they formed this biking group and they just bike around the park with their masks on, right? So around 5 o'clock, it's an expectation. He wants to go out. He knows he's not gonna have an opportunity to interact with his friends or play with them, but he can bike in a group, right? So how do we take advantage of social cohesion, group settings, and try to enforce some of these principles of physical activity? And like Mo said, everyone knows the benefits of it, right? But we need to make the neighborhood environment more conducive so that people want to naturally go out and move more, right? And getting 10,000 steps a day may be different for one person. They can get it at work. If their work involves moving around all day, they may get that 10,000 steps. So even though it's not leisure time physical activity, they're meeting their targets. But for someone who sits behind the computer all day, like me, I need to actually take some steps after work to force myself to get the physical activity. So we need to ask the right questions, and we need to advocate for policies to improve the neighborhood context and make it easier for people to stay active in the community.
Yeah, exactly. Before we move on to Adama and her question, I just wanted to ask if people on this Zoom call or on social media had questions for our panelists. I'll give them a couple of seconds. Any questions? If you do have questions, definitely put them in the Q&A or ask them on social media, and our other moderators or our other co-organizers will take a look at them and we will ask them to the panelists. Adama had a question, so I'll let her ask it.
Thank you, everyone. All your points have been so amazing to listen and to hear into. I guess my question is, what difficulties do you face when communicating your message? Because I've realized as I went through my undergrad in medical physiology, I would tell my parents like little things here and there, like, oh, this might not be good for you, or this might not be good for you. But then you find out the people closest to you are the hardest to convince to do something, while I know people furthest away will listen to me in an instant, but the people that I guess you might care for the most are quite difficult to get the message you really want to get to them. And also the emotional aspect, because you understand why they do the things they do, you are more likely to turn a blind eye and stuff like that. So in all your practices and your work, how do you deal with those quite challenging situations? And maybe if you have examples that you can share on how to actually push a message to people that you feel really need to take it in. Sometimes you like, so there's the nice way in explaining it to people, but when you actually have to go down the harder route, how have you done it?
Okay.
I think you actually touched on a great point, Adama, in that sometimes when we're close to someone, it's the hardest for them to hear us. And I'm experiencing this right now with my mom, right? She has some concerns about the way my brother has been eating recently. And so I said to her, well, Mom, you kind of nagging him about it is not actually the thing that's creating the change. And the way that I approached it was having someone else who he might listen to more, someone else who he might follow more, be that person to speak to him, or maybe share, hey, this person is doing this, knowing that this is somebody that he looks up to, might make him more want to listen to that person more, where sometimes you're coming from people who are close to you, it's like, okay, I hear the same thing all the time. So I think just having a different support system that will help you get that message across to the person in whatever way or forum.
Yeah.
Having that additional support might help.
Definitely. Sorry, I'll let you speak.
Okay. I definitely think modeling and living by example is definitely a great way to get a point across to people, and that are close to you, especially when they begin to see the benefits of you taking that decision or going down a certain route. They will decide, okay, right, maybe I should try this as well. Maybe this might be beneficial. I've seen this more so, something quite off topic, with going natural. And when I went natural, I looked silly to my family. But then when they began to see the benefits of my hair growing back, my hair becoming a lot thicker, a lot healthier, they were like, maybe I should try this natural thing. But when it comes to diet and exercise, it was actually the opposite for me, in a sense of I was the one that had to be convinced by my mom and my brother to live healthier. And they did it in an interesting way. They did it with love, but also with supporting me. So they didn't just say, go to the gym. My brother would wake up at 5 a.m. and take me with him. So, that was the support that I needed to kind of push myself until I was able to take over and, get in that exercise. So having that support system definitely helps. So supporting that person, literally holding their hand until they're able to hold themselves, and also living by example, I think definitely helps.
Definitely. Thank you so much. Oh, Nilal, go ahead.
Yeah. I just want to add to what Mo has mentioned. I found that like leading by example has been the best way to teach these changes, because I think for a lot of people, like this way of living it's new. Like because we're in the industry, we understand the importance of it. But I think on a larger context, like choosing to eat healthy or exercising, these are all relatively new things for the Black community. And I say that while at the same time I can say that they're not. I think that the ways in which we're learning them and being introduced to them now is new. That's why leading by example has been the best teaching method for me, because I think in health and medicine, I have observed that Black people are quite distrusting of systems that want to tell them about, what to do with their bodies. I know personally I am. So I'm not always receptive to someone just saying, oh, you should eat this, or you should do this. And so just live the way that you want to inspire people to live. So I just wanted to highlight that, because that has been the biggest tool for community transformation that I see. If you live healthy and people see that, oh, okay, she's doing this and she's happy, she's active, she has all this energy, she's glowing, people are more likely to then start making those changes as well. And also I love the natural hair parallel, because that is so true. Yeah.
Definitely. Our moderator, Adama, has a question for Dr. Alexander.
Yes, I have another question. I think this stemmed when you mentioned echocardiography, and because my master's is in that, I struggled with understanding why reference values, especially used commonly in practice, didn't really include populations that were Black. And I just want to ask you, I guess, directly, how do you think this affects the overall just management of patients, especially within Black communities, if these values aren't really representative of us and our heart structures? Because I guess an annoying point I found is whenever they reference Black communities, they would reference heart values for Black athletes. But when it came to the normal data sets, it was nowhere to be found. So I'm like, this is something that can be done. But I guess the wider research community just hasn't found a way to do it properly yet. So,
Yeah, that's an important issue. I think there's a couple of things I'd say. First, from a research standpoint, we need to be more inclusive of diverse populations. And, I think a lot of funding agencies are really trying to promote that. So, the NIH or the American Heart Association are the ones I interact with the most. And, when you do clinical studies, you really have to, if you don't have a diverse population, you have to justify why you don't. And I think it kind of gets at this, if we kind of come up with normal values for things in a very narrow sector, narrow ethnic and gender sector, that, makes it harder to generalize that to other populations. And so, hopefully over the coming years, we'll have a better sense of that. I think for what we have now, it is a problem. And that's one of the reasons why I think with heart failure and cardiac amyloidosis, there is a lot of misdiagnoses, because I think there's a tendency to, when a Black patient comes in with, let's say, hypertrophy on the echocardiogram, it's hypertensive heart disease. It couldn't be, something else like amyloidosis, right? And I think so we kind of have to move away from medicine of saying that, okay, we see these findings on EKG or echo, whatever the test is, and it means X. I think you have to integrate race and sex into that equation, and understand that in certain populations, those same findings could be, should raise a suspicion for other diseases. So, I think it requires a lot of education, and it requires, kind of broadening our ongoing research to try to tackle this.
Definitely, which actually, which brings us before we go to our next point, Jason has a question. So is saying that, to follow up on Adama's point, when people think of athletes, they usually think of Black people, but we are still regarded as the most unhealthy community. How do we change the narrative that you don't have to be an athlete to be healthy?
Right.
Yes, anybody has an answer for that?
One of the greatest thing, like I said, I was born in Jamaica, but I grew up in New York City, and I came to the Bay Area about 3 years ago. And when I came here, one of the things that impressed me about the organization that I work for, Kaiser, was everywhere in the community was images, subliminal images of Black people in everyday activity, walking in the park, just doing different activity that says they're healthy, riding their bikes. So I think a lot of it is the images that we get bombarded with on a daily basis. Are those images truly reflective of who we are and how we're showing up? And I think, even as, again, if you're involved in policy around your communities, is to put up billboards that are truly reflective of how we actually live our lives. And that will help to change the narrative.
Ms. Chang, did you have a question? Did you have an answer? I'm sorry.
Were you asking myself?
Yes. Do you have a comment to Jason's question about?
Okay, I guess it's important to just, like, Amelia just said, diversify how we're represented. I think people normally look to, like, mainstream medias to define, Blackness and define how we are. And, we do know that sports is somewhere where we're highly represented. If it's not, unfortunately, in, like, crime and negatively depicting us in, like, sitcoms, it's usually like sports, right? So diversifying and just depicting us as normal human beings, because we're not these, like, we are special in our own right, but we are just human. And I think the more we humanize Blackness, the more we don't all have to be athletes to be seen as healthy. The more we're represented in medicine and in research and in diet books, and where they teach children about diets, the more our foods are represented, the more the type of exercises that we like to do, the more we're seen. I believe those kind of stigmas or stereotypes will change.
Definitely.
Yeah.
And Jason and Adama's questions are bringing us to our next, the next part of this equation, which is medicine, which encompasses everything. And I think Dr. Alexander, because you're an MD, obviously you have that patient interaction, but I'm sure Dr. Mensah, within your research, and Ms. Chunk, and then Nilau, and Ms. Blake and Ms. Tillman, all of you have had to interact had to interact personally, or had clients or participants interact with the medical world. So you do understand some of the issues that usually come with Blackness and medicine and cardiovascular diseases. So my next question would be to know, when it comes to medicine, let's talk a little bit about how medicine contributes to the disparities in cardiovascular diseases that we actually see. So so when I talk about it, I'm looking at the unconscious and conscious bias that we see in medicine. How does it contribute to cardiovascular diseases and the issues of cardiovascular health within the community? And the second part of my question would be to know, how does it fit into the narrative that we need more Black doctors? Because we've been hearing that a lot, like, with the advance of social media, now we are seeing all these examples of how Black patients are being treated. And now with COVID-19, we are seeing Black patients dying at a higher rate. And part of it is also due to the way that they are treated within these medical fields. So how does it fit into our conversation around these issues of cardiovascular diseases that we see within Black communities? And definitely the other thing I want our audience, if they have questions for our participants with regard to this question, they should definitely ask them. So anybody is going to start answering this question? Nilau, I see you are thinking about it, or Dr. Alexander, because you are an MD. How do we? I guess you have that direct experience with regards to the issues that we see in cardiovascular health and medicine, the issues that we see in medicine.
Sure. I think there's a lot of layers to this question, and so I think even if you're not an MD, if you intersect with patients and black people with cardiovascular disease, those viewpoints are really valuable. So I guess I'll try to touch on maybe some of the more clinical aspects of it, but would love to hear what other panelists have to say. I think it kind of goes back to some of what I alluded to earlier, is that disease is, we talk a lot about precision medicine. That's kind of a buzzword that's been around the last 5 to 10 years about, trying to, apply therapies and diagnostic pathways to specific patient populations, and not just having this wholesale approach to how we interact with patients. And, I think that that's particularly relevant among African Americans, because there clearly are differences from a disease standpoint. Certain diseases will affect different racial ethnic groups in different ways. And, I think that a lot of times what happens is that the things that we read in the textbook, that, how this disease X looks, is based on kind of studies that were done in a very narrow population, of patients. And so things like amyloidosis or other forms of heart failure, for example, may just look different among African Americans. And so if you look at through a lens of this is how it looks in Caucasian populations or Asian populations, you might miss some of those early findings. And so we have to, I think, it starts in medical school, at least, kind of educate about how to really factor in race and gender in terms of diagnosing patients or interacting with patients. So I'd say that's one of the things from a medical standpoint. I think there's a lot of issues around access, whether that be through insurance, proximity to medical centers. And so, I'd love to kind of hear what other people have to say about those things.
Definitely.
So
Dr. Mensah?
Yes,
Yes.
sure. To add to Dr. Alexander's comments, work by Dr. Lisa Cooper and others have shown that when African Americans see an African American provider, they're more likely to rate their visit as participatory or more satisfactory than when they see physicians of other races. And so that has been described as what race concordance versus what race discordance. But in as much as I acknowledge that we need to increase diversity in the medical workforce, I think that we need more providers who know how to care for Black bodies, regardless of their race. So there aren't enough Black physicians in the US to ensure that there's that race concordance. So we need all providers to care for Black bodies and care for them well, and provide evidence-based therapies. So that education starts very early on, whether it's medical school, nursing school, pharmacy school. We need to teach providers to treat patients equally and ensure that everyone is getting the right level of care and the high quality care. So in short, as much as I agree that we need to increase diversity, I think all providers need that education, and we should all strive to provide culturally competent care to all patients, regardless of their race and ethnicity.
Yes, Ms. Stillman and Ms. Blake. I guess I'll go with Ms. Stillman first.
Okay, thank you. Yvonne, you just triggered upon something that in all the teaching that I've done with the medical students is that they have to figure out some languaging that allows the patient to know that the practitioner is their partner in their healthcare, right? Like if I know that I have a partner it doesn't really it doesn't matter to me, are they black, white, like what they look like. But if it's not this intimidation, like I have the white coat and you don't, when that dynamic shifts and it's like, wow, no, you really want to hear and about what's happening for me so that I'm thriving in my life, then I'm all about it. So then there's intimacy, and then I can trust, and I can say the thing that I'm embarrassed to say. I can ask the questions. So I think that's really huge. It's that, and I would, that's one of the biggest things that I've always brought to my students. It's how are you positioning yourself physically? What languaging are you using that seems and feels inclusive, as opposed to like, oh, let me just use this word that I know you don't know what it means, right? That has someone feel excluded, right? There is already such a dynamic, again, like, oh, you went to school, I didn't, I'll just do whatever you say. But meanwhile, I left and I didn't tell you that I have this lump, and I just didn't mention it because I was intimidated. So I really support what you're saying, like, let's create continuous partnerships so that the patients keep showing up and that they're interested in their care.
Miss Blake?
I love that. I just want to touch on something that Dr. Commodore Mensah mentioned, and it was around teaching providers. Now, here in California, I don't know if you guys are familiar with Dr. Nadine Burke-Harris, and she's the first California general, and she is spreading ACEs aware. ACEs is adverse childhood experiences. And they did a study that showed, one of the longest study that showed how the experiences that you had in childhood, how they later translated to a lot of our health issues that we have today. So one of the things that she started doing as of last year was training all the providers in California around ACEs aware and how to assess that when you're in front of that patient. And it is one of the best trainings that I've ever seen put together. And most recently, they came out with the data of how many providers have already taken this training. And the training is geared towards the Medi-Cal population, which is a lot where you'd find the African-American communities. So it's teaching providers how to assess those issues, and then deal with it with that member on an individual basis. I love how healthcare is moving towards patient-centered care, where the patient is at the center of all that you're doing, and being that partner, as Janet mentioned, with them, understanding what their individual challenges are will then help you to create a better lifestyle choice for that individual. So I love the work that she's doing.
Definitely. Ms. Chang, you had a comment? Or
so mine's more, obviously not a doctor, but mine's more like social commentary in terms of, some of the unconscious biases that, are held towards, persons of color, Black people. And, I think one of the biggest one that's, made it into the media is, this idea that Black people can tolerate pain a lot better. And so for that reason, sometimes our concerns, or, you have a tightness in your chest, is not taken as seriously as, a white person, for example. In some cases, I'm not saying this is all the time, but in some cases, not taken as seriously. You're not, taken for the scans as readily as, other persons would be. And those are things, early diagnosis, we know in medicine is very important and can be life-saving. So when you have situations like that and things are left unchecked, then it's more likely that diseases such as, what you mentioned, I can't remember the name of it, something to do with cardiovascular diseases. Cardiovascular diseases are more likely to, take their lives away, and, before you know it, people are gone. Whereas if that unconscious bias of they can tolerate pain better, or they're just, dismissing their viewpoints, if that's not there, then more of us would, be saved very early on as well. So yeah.
Definitely. And Nilau, you had Miss Nenongola. I keep on saying now because I know you. So Miss Nenongola, you have a comment.
Yeah, that you can call me Nilau, that's fine. But I wanted to speak from so I'm the person who deals with, you know, the patient or the client after they visited the doctor and learned that they need to make these lifestyle changes. And I just want to echo that. I think that there needs to be like radical transformation in the service provider's office, because there's a disconnect. Because when, you know, someone comes to me and they, you know, they say they've been put on this medication for, you know, whatever it is, I'll ask questions. Okay, you know, why did they put you on this medication? How did you come to this? And what I found is that a lot of people are not comfortable truly expressing, you know, what they're struggling with or their pains, or because I see there's a lack of trust. You know, there's no sense of feeling safe. It's not a partnership, essentially. So I do think, you know, while there is a lot of education that needs to happen around people understanding what is happening within their bodies, I think greater impact would happen if there is also radical transformation in the offices of the service providers, like what was mentioned before, like really understanding how to interact with Black bodies, because that's just an area that is not addressed. It's lacking. Work needs to be done there.
Definitely. So we probably at some point, if we have time, we'll come back to medicine. But before we get to so we talked about diet, we talked about physical activity, we talked about medicine, but there is the research component of it. Because a lot of things a lot of the treatments, a lot of the way that we do prevention are really guided by research. But the problem is that we have issues are twofold. So we have first, and we've talked about it a lot in these conversations, the lack of representation when it comes to Black people in these medical, Black participation in these these studies. So clinical studies and these just large longitudinal studies, they don't have an adequate representation of Black people. So when we do prevention programs, asking people to eat this and that diet, sometimes you don't necessarily know what works for Black people, and you don't necessarily understand that Black people are also very heterogeneous, even within the African American population. You have the South, you have the North, you have the Midwest, and so forth. So you cannot give the same type of advice to people in different regions of the country. So that's one other issue. But the other issue is the science communication. So we are dealing with issues of cardiovascular diseases, but I think science communication, we are living in a pandemic right now. So science communication has become a very, very important because now there's this huge light on science. We are supposed to be giving people these answers with regard to their health, and it feels at times that people feel that we are failing them. So my question would be to know, how do we increase the importance of science communication and make scientific information more accessible to the general public? When I talk about scientific information, I'm talking about obviously the research, but I'm also talking about the work that Nelau and Mo Chang are doing, because you have to communicate your knowledge to people. How do we make it so that we can communicate the work that we are doing, the scientific work that we are doing to the general population in a way that is accessible and in a way that is understandable?
Okay.
All right.
Do you want to go first?
Yeah, so it's a really tricky place to be, because we literally have to, I don't know, maybe you can add to this, Mo, is like you literally have to take this science and complicated way of phrasing education and then distill it down to digestible and relatable information. I sometimes, of course, I try to educate in a way that is simple and intuitive and easy to understand, and really try to take, yes, the knowledge that is there, but empower people to heal their own relationships with their body so that they understand the choices that they're making with the information that they have. But a big part of that is really making it more relatable. So using examples that people can relate to, or offering tools that are available to them. A lot of what I've seen is just things that are not, they're not accessible and available to everyone. So, yeah.
I think definitely in terms of like passing on, you know, that information, quite similar to Nilao, just making sure that you're speaking a language that is understandable. And I think, you know, probably everybody here on the panel, you know, in their education, their various levels of education, they know that, you know, when you are writing things like essays, research, what your lecturer is looking for is, do you yourself understand it? And, you know, one of the ways that they do check that is that, are you using complex language all the time, or are you breaking it down in a way that if you explain this to somebody that wasn't an expert, would they understand it? So definitely I try to translate that in the work that I do. And because, you know, I'm into media, I'm a presenter, I carry a friendly tone into like everything I do, because I find that sometimes on the internet we talk at people and not to them. And people are less likely to listen when you do so. So I always try and approach things in a very friendly manner. And in terms of making things more accessible, I think it's adding to the work of all the amazing like Black people that are already out there talking about diet, exercise, medicine, research, because there's not a lot of us, but we are needed. And we are needed because we need to speak the language that our people understand. You find so much, and I'm sure with itself, Nalawo, that when people do come to you, they're like, oh my gosh, like such a breath of fresh air. Like I've not seen something like this for us, because we're often excluded in like mainstream conversations about diet, exercise, medicine, research. So having people like us joining in that conversation, there is a lot of us, but there's so much more that is needed. And, you know, just being inviting and making sure that your work, something that I probably could do a bit better is shout a bit more about my work, and, you know, really share it more with the world. So I think sometimes we post it once and we think that's enough, but like there's so many people out there that it could reach, making sure that, you know, your website is up to date with like SEO, and making sure that it's searchable, making sure that, you know, you're on panels like this, making sure that just shouting about your work a bit more, because there is so little of us on the ground doing the work, but it is really important for us to shout more about it so that they can find us as well.
Definitely. So I am going to turn to Dr. Alexander. So Nelawu and Mochang, you guys talked about you are on the ground, you are dealing with the aftermath of the research that is being done. So Dr. Alexander and Dr. Commodore Mensah, how do you go about doing science communication? Because we are, as scientists or as researchers, we are the ones writing the papers, and we are the ones making the research. How do we communicate it in a way that is understandable? Because I think we have to start thinking of research as this trickle down thing that happens. So if it's not understandable, if it's not well communicated at the highest level at the beginning, then we have a problem. So how do we go about doing a better job at it?
Yeah, I mean, I think you know, I see the communication as two avenues. So I think as Black or, you know, minority researchers, we have the duty or, you know, opportunity to stress the importance or highlight or demonstrate the importance of doing research that you know, looks at diverse populations. So I think we have to communicate with our colleagues in the scientific community to stress that importance. So, you know, on that kind of academic level, I think the more that we do, you know, research and show the, you know, importance of these things at conferences and in papers, that's one piece. But I think in terms of reaching the lay public or the general public with the importance of these medical issues, I've found it. I've done this more in the last couple of years. Is participating in these community-based kind of conferences. So for heart failure, I've participated in Healthy African American Families, which is a conference that is done in California, as well as Healthy Churches 2020. And so they have a broad range of topics that they cover, multidisciplinary. And so, the stuff I talk about on heart failure is a very, very small piece of that. But the content that I go over in a conference like that is very, very different than it would be, for a scientific conference like American Heart Association. And, I think it's easy to get bogged down in data and, statistics and that sort of thing. But, I think if you distill it down into here's the problem, and these are some of the things that we can start to look at to correct it, that's something that is very tangible to people. And so, one of the studies I did for cardiac amyloidosis was really, I looked at Centers of Disease Control information over the last 30 years and basically showed that that the diagnosis rate of amyloidosis is increasing over time. We know that African Americans tend to have higher rates of it, but when you looked at the geographic distribution of amyloidosis diagnoses, there's this huge mismatch. So you would hypothesize, if you're looking at a disease where that primarily affects African Americans, you would see higher rates of diagnosis in the South, for example, right? And maybe in the Midwest or other areas, the rates would be lower. But we saw the exact opposite. So I put a map of kind of the proportions of African Americans, and so in yellow, or let's say higher rates are in the South, and then Northeast and other places were lower, and then the rates of amyloidosis diagnoses, and it was the exact opposite map. Right, so the South had the lowest diagnosis rates, and so there's a huge mismatch. And so I think just showing those two maps, you don't really need to know anything about the biology of the disease or what it affects, but I'm telling you that this is this deadly disease, and this is how bad we're doing at diagnosing it. And so I think that kind of sets up the problem very clearly, and then you can start to talk about how do we go about fixing that or addressing that. And that's a two-way conversation, because we have to work on things from a community level, and we have to work on things from a medical perspective as well.
So Dr. Mensah, I'll let you talk. Then we have two questions from social media, so you can go ahead.
Sure. So one of the challenges is that in healthcare and in academia, there's sort of a misalignment where in terms of progression and advancement, you're expected to bring in these grants, publish papers, but unfortunately, in terms of community engaged research or work, so for instance, if you give presentations often in community-based settings, often that's not recognized, or that's not accounted for when you think about promotion and tenure. So that's one of the big challenges. And you find that a lot of academic institutions are considered these ivory towers. So I'll take Hopkins as an example. Hopkins is situated in Baltimore, Maryland, and just within 8 or 10 miles of Hopkins, there are very high rates of hypertension, diabetes, heart disease, and it makes you wonder, when you have an academic institution that has a lot of resources, knowledge, how is that not translating into better outcomes for the community, which requires that we need to, get out of our cubicle spaces and go out into the community. But until incentives are aligned, and I just want to acknowledge Mo for the work that you do. I think we need to do a better job of collaborating with these, what I would call, I think you call yourself a media mogulette, right?
Yeah.
Or brand influencers, right?
Yeah.
We need to be sliding into their DMs and seeing if they can pass on some of these public health messaging. So since TikTok was launched in 2017, there are over 800 million users, right? And WhatsApp has over 2 billion users. Why are we not in these spaces and passing on these health messages so that people can improve their heart health? Why are we not collaborating with these brand influencers and actually paying them to pass on these health messages? We shouldn't expect that they do it for free. If we're saying this is of value, how do we connect with them so that they can champion the cause? And as much as healthcare professionals are experts in their own rights, I think we also need to acknowledge that these people have found a way to garner, 8 million followers or so. And how do we use that to our advantage and work together to improve heart health? So if there's anything I would advocate for is trying to get a better handle of using social media effectively, especially for the younger generation. Women of reproductive age who, on average, people spend at least 2 hours a day on social media, right? So what are we doing with that information? How are we going to use that to help promote heart health? So that's all I would add.
Yeah,
definitely. And to get to this point, I guess that's why we have spaces like Black in Cardio. We hope that people will start thinking of collaboration as a different thing. So we have our panelists here. We have Mo, we have Nilau. They are doing excellent work at letting people know about diet, about physical activity, about cardiovascular health. So the scientific world, these big institutions have to start thinking about hiring them and collaborating with them in order for, if we are really serious about lessening these disparities in cardiovascular, racial disparities in cardiovascular health, when you look at hypertension, diabetes, heart failure, people should not have to die from that. Cardiovascular diseases are the #1 killer in the world and in the United States. And there are huge racial disparities when it comes to Black people. Black people are dying more and they are dying younger. And that should not happen. So we have to start thinking about these different ways of collaborating. So if institutions are hearing us, if hospitals are hearing us, we have specialists here. We have Mochang, we have Nilau. Reach out to them, work with them, because they have found a way to reach out to the public. So we have a question, because we have like 11 minutes left, and Adama has a question, she has a comment, and then we have a question from social media. Hopefully we have not missed other questions, but if we have missed those questions, definitely reach out to our panelists and interact with them on social media. So the question is from Dr. Dapple, is asking, what role should institutions play in responding to racism experienced by Black cardiovascular professionals in the workplace? And then, and he has another question. So I'll ask that the first question, and then I'll ask the second question. So we are talking, so I'm assuming now we are talking about, mostly we're talking to Dr. Alexander and Dr. Mensah. What role? Yeah. Because you guys are within these academic spaces, which are, we have to be honest, were never created to have Black people in them. So we have a lot of issues of disparities when it comes to the funding, disparities when it comes to tenure, and ultimately, because there are these disparities in these spaces, that translates into what's the kind of experiences Black people have. Because if you don't have Black cardiovascular researchers or Black cardiovascular doctors, the consequences are on the bodies of Black people. So how do institutions go about doing a better job at it?
Yeah, well, I think to change the structure of academic institutes, it comes from the top. I mean, there has to be, buy-in, or not buy-in, but there has to be support that, there has to be a mandate to say that, we want to have a diverse and inclusive, faculty and staff, because we believe that goes in tandem with our mission as an academic institution, improve the health and wellness of society as a whole. And so, I think it's, disingenuous to say that you're doing that if you don't have faculty and staff that reflect the general population. So, I think that, various institutions are in different stages of doing that. I think a lot of places, and, including my institution, they're really, doing a lot of efforts at the training level as well as junior faculty level to try to encourage a diverse body of trainees and junior faculty to go into academic medicine and to stay into academic medicine, because that's going to really, I think, help to make sure that we're doing research and clinical care that is in the best interest of a broad range of people. I think so I think that's where a lot of this will have to start, is at that stage. And we just kind of have to push people. I think with COVID and the clear disparities in terms of mortality and morbidity, there's been all this stuff that's been going on with violence over the last several months. I think it's kind of galvanized people to look at this more closely, and we just have to make sure we keep maintain that momentum. So when kind of these news stories kind of die down and the public interest is not where it is now, that we're still making that push in academia to improve the diversity among our staff.
Yes, Dr. Massa.
So that's a very good question. I think a good place to start is for healthcare institutions to acknowledge that just healthcare is not immune to racism, right? Healthcare institutions, academic institutions are not immune, and it's hard to acknowledge that. And I think once you acknowledge that, then you collect data. A lot of these healthcare institutions are all about data, and data drive a lot of decisions. So I think if you really want to know the climate and to know the experience of Black cardiovascular disease researchers, cardiologists, trainees, collect the data, conduct a survey, and you'll know. Because often people have these conversations, and a lot of us who've experienced it talk about it, but somehow if you report it, it stops there, right? And there's no way to track how often these reports are made, if there are any follow-up steps that are, or actions that are taken. So you need to understand what's going on. And once you have that data, the question is always, what do you do with it? Well, it's a start, right? The leaders of the institution may not have all the answers, but there are experts, right, who can help in terms of learning how to change the climate. And it's hard to really change people's mindset, right? But you can institute measures to ensure that there's accountability. So we talk about the fact that Blacks may not receive the same level of care when you compare them to whites. Until you look at that data, you can discern that there's a difference. So if you notice this trend, then you can show the data to a provider if that disparity exists and ask questions. So how come of the 100 patients that have received this procedure, these are the outcomes for your Black patients? I mean, it's radical when you think about looking at data that way. But until there's accountability, I think we're going to be stuck in this state of knowing that these disparities exist without actually taking action. And accountability is completely missing, if you ask me, when it comes to racial disparities in healthcare. So I'll stop there.
So we have another question. We have 4 minutes left, 5 or 4 minutes left. So Black participants, from Dr. Dapo, Black participants are frequently underrepresented in clinical studies. Should funding agencies play a role in ensuring Black participants receive equal representation?
I think for NIH-funded clinical studies, there's been a push in that direction to have some accountability for diversity in their clinical trials. From industry-sponsored trials, I think that there also needs to be, there's kind of more variable what that push is. I think a lot, like we've talked about a lot, that to improve the diversity, it's important for us to have a seat at the table. And so I think that there's, a lot of conversations around having more inclusion of Black and other minority clinical trial site PIs, for example. So having people at these institutions, people of color, they're actually running these clinical trials. I think that that's going to be a key component to increasing inclusion. And so, I think that's something that, academia, I think, as well as industry, we have to figure out how to improve the pipelines of getting junior people into these, because sometimes it can be, I think that the path into running clinical trials is not, a linear path that, you finish your training and now you can run clinical trials. A lot of it is about who you know and connections. And so to really, we have to have something that's disruptive to help other people break into that. There's a piece that some of my cardiology colleagues at other institutions published not that long ago that showed that if you look at a lot of the heart failure trials that have been done in recent years, not a single first author was a woman, for example, right? So, it's kind of hard to say that, we're kind of doing justice to, doing trials that affected broad population, and yet really kind of a very narrow subset of people are running these. So we have to really kind of figure out how to have a more inclusive population running these studies. And I think that I don't think that alone will suddenly increase trial enrollment of Blacks overnight, but I think that's one key piece. And then the other thing that we've kind of touched on a little bit is the mistrust in medicine. And I think that suppresses clinical trial turnout too. And I think this mistrust is not, there's reasons behind it, right? So my family, my mom and my grandparents grew up in Tuskegee, so it's not, I've heard these stories, so it's not an abstract thing. So I think we have to improve our education about what the education around the importance of clinical trials, and how a lot of times it can be a really opportunity to receive cutting edge medicine. And if you want to, that, I think that's a key piece of coming up with therapies and making sure that they are of benefit in Black populations. If we kind of just after the fact do a trial, there's low Black enrollment, we're kind of assuming or hoping that these drugs are efficacious, but we really need to, it'd be much better to get that data up front in the initial study to understand that.
Yeah. I guess we have 1 minute left. So just I wanted to thank our participants. And then also definitely one thing that we have heard and we keep on hearing is that we need more Black representation in research, in medicine, in wellness coaching, in teaching with with Ms. Blake and Ms. Tillman. We need more Black representation, because if we don't have that representation, ultimately the people that are suffering are Black bodies. This is why we are seeing some of these disparities, because these spaces are very, sometimes they are very limited. We cannot break through some of these spaces. So it's very important for us to get there. But at the same time, we also have to recognize that there are reasons why we are not there. So we are all operating within a very specific system. So we need allies, we need partners that are willing to go to the bat for us, because we cannot fight this fight by ourselves. So definitely these conversations need to be had. And I really want to thank you for being part of this panel. And I hope, like we mentioned, that institutions will start looking at a more interdisciplinary approach when it comes to cardiovascular health. Again, Black people should not be dying at higher rate from hypertension, diabetes, heart disease, and so forth. So we need more interdisciplinary approaches to that. We have Nelau, we have Mo Chang, we have Ms. Tillman, we have Ms. Blake. These are experts in the work that they do. Reach out to them. So thank you so much, and have a nice day.
Thank you so much for having
the
us.
opportunity. Thank you.
All right.
Take care, everyone.
Bye-bye.
Bye.
Bye.